Hello, my name's David Doig, consultant neuroradiologist, and here's an example of the type of case that we'll take you through on the course. It's a spinal tumour, and you'll see some dedicated cases for that. Here's an intramedullary lesion at C2 level that looks a bit odd. There isn't much edema generated by it. It hasn't caused a syrinx. It appears to be a solitary lesion, and there's a little bit of low T2 signal at the top and the bottom of this at the cranial and the caudal end, which sometimes makes you think of something like an ependymoma in a younger patient, the hemosiderin cap that's described in the textbooks. But a little bit odd that these other features are missing. And when we look through all the other sequences, actually there are some other odd things as well. When we look at the pre-contrast T1, we see a little bit of hyper-intense signal, meaning that this has bled before. And when we substitute that with the contrast images, we see there's very little patchy bits of enhancement, but really no strong homogeneous enhancement of a soft tissue component, which might be considered a little bit unusual for ependymoma. And the answer to this case really is contained on the T2 sequences. If I look at the axial T2, I see that this is an intramedullary lesion, yes, taking up most of the transverse diameter of the canal and quite expanding the cord. But on this medic sequence, T2 star weighted, we actually see some blooming artifact around the outside. Blooming meaning that the signal dropout that we see in gradient echo or SWI is larger than the anatomic abnormality in real life. So we come back to the sagittal images here, and we see that actually this has quite a sort of bubbly popcorny appearance. And when we think about masses and tumours in the spine, we've got to think very broadly about that term tumour, because any tumour that you can get in the brain you can often see in the spine as well. A glioblastoma in the spine could look like a glioblastoma in the head, and similarly with this case, a cavernous venous malformation, a cavernoma in the spine, could look the same as the cavernoma in the head. We might take the T1 hyperintensity if it was new as evidence of some recent bleeding, but this one hasn't bled recently and there's no edema surrounding it. So the surgeons are not in a rush to excise this lesion, even though it might pose a bit of a risk to the patient. We hope that you'll join us for our launch webinar coming up, where we can look through some more typical cases and let you know a little bit more about the course.